It's an honor to introduce our lineup of experts. With us today, we have Jalen Garrett from Johns Hopkins Sibley Memorial Hospital, nurse practitioner, and Dr. Carmen Cutt, radiation oncologist with Johns Hopkins. Additionally, we have a very special participant, our very own survivor, Michelle Hills, who is joining us via Zoom from home. Following the presentation today, another amazing survivor of our community, our very own Cheryl Elliott, will facilitate the Q&A. So please go ahead and enter those questions. At this time, I'll turn the program over to our friend Michelle, who's joining us via Zoom.
Hey.
Hi, Michelle. It's wonderful to see you today. Can you hear us?
I can.
Hello, friend. Tell us about your experience.
Okay. Well, hi, everybody. For those who are new, welcome to our community. For those who have been around for a while, hello, my dear friends. I love you all. So my name is Michelle Hills. In 2018, I was diagnosed with ALK-positive lung cancer. Like many of you, it came out of nowhere. It was a total shock and surprise. I was a, elite athlete, a pharmaceutical executive, and like my career was rising, and then it was over in a blink. Fortunately, after a second round of molecular testing, the ALK mutation was identified, and I started on alectinib. And from that point forward, although there were a few bumps in the road that required a dose reduction, I remained no evidence of disease for a long, long time. Although the scans were never routine, and there was always, some trepidation and anxiety leading up to them. For 5.5 years, my scans were clean. Okay. And so I didn't really, worry too much about it. But the words leptomengeal disease came into my life when I was participating in the longevity peer support forums. This was during the pandemic, and the longevity Zoom sessions, they were here we go. What's this? Okay. So the longevity support sessions were our lifeline to the world. We only had each other during that time. And during that time, there was one of our members in the Midwest who developed something called leptomeningeal disease. And the only thing that I can tell you is that her story was powerful. I'd never forget it, and it stayed with me for years after her passing, because one day she was in the Zoom session on a Thursday, and then she didn't show up on the Monday Zoom session, and that's when we learned that she had passed away. So the time between her diagnosis of leptomeningeal disease and her passing was very short. It was only a couple of weeks. And so the one thing that I took away from that is, if you ever have a headache that's not going away, pay attention, because it needs to be addressed. Now, since that time, there's a lot of hope, because there's more treatment available, or there is treatment available for leptomeningeal disease. So fast forward 5.5 years, no evidence of disease on alectinib, and I actually had clean scans. There was just the thoracic scans. I wasn't due for a brain scan when I started having persistent headaches. And so one of the things that I also learned in the longevity forum, that is, if you have any symptom that lasts for longer than 2 weeks, you've got to elevate that concern to your team and have it addressed. But this is where the frustration comes in, because leptomeningeal disease is new. And I started reporting these headaches immediately to my endocrinologist, to my primary care physician, most importantly, my oncologist, and they were all dismissive of this headaches, these headaches I was having. And my oncologist said, cancer pain doesn't come and go. Use supportive measures, take Tylenol. Well, after a couple of weeks, I started throwing up um, in the mornings after breakfast, and I thought, this has got to be addressed. I went on vacation, went to the Bahamas, was told I was medically cleared to come back, but when I was, on vacation, I was throwing up even more, and I was looking for garbage cans all over the cruise ship. So as soon as I got home, I called my oncology office and I got pushback from the nurse when I asked for an MRI of the brain. And she was a brand new nurse. And at that point, Lori's story, Laura's story kicked in. And I said, no, I have to take control of the situation. And I told her, no, no, you do not tell me whether or not I need the MRI. I am telling you there's something very wrong and I need a brain MRI and I need it immediately. So she went back, she talked to the doctor, they got the MRI scheduled. It was a God-given thing that it was scheduled for the next day because you all know how hard it is to get a brain MRI these days. And when I went into the outpatient clinic, I passed out in the parking lot. And then I started talking in a gibberish. In my head, I was articulating sentences, but I was articulating a gibberish. And when I went into the brain MRI after I came to, I asked them to go get the radiologist. I said, I think we're dealing with an emergency. Go get the radiologist. And they said, we don't normally do that. And I said, I'm not asking about your normal process. I'm telling you, go get the radiologist. I think we have an emergency. And so I don't know who was telling me to do this or how the words formed, but from that point forward, my life changed again for the second time forever. I was hospitalized 3 times while they were running through the diagnostics. I had a hospital team telling me, you only have a few weeks to live, get your affairs in order again. And then I had shiny, happy people that showed up into my room, radiation oncologists. They are optimistic by nature. And they said, there's something called proton whole brain craniospinal irradiation radiation, and we think you're a perfect candidate, and we think that you're going to do well. So you can just imagine like the whiplash that we had. But that's what I did. I did this experimental treatment. I went to Memorial Sloan Kettering and I went to MD Anderson and I got second opinions. And the therapy worked. For some reason, I breathed through the proton, did really well. And then I switched my targeted therapy from alectinib to loratinib. And so what I found is that leptomeningeal disease you can live with. Here I am, I'm 17 months later, so it's not the end of the world. Um, I'd say to anybody, if you go online and you look for leptomeningeal disease, if it's more than a year old, it's already too old. There are no clinical trials, and all of the clinical experience is occurring with these siloed experts that are, doing basically experiments in the clinic. So I am still here. I'm living the best life that I can. And I made this commitment to Laura Greco, before she passed, that I would do what I could to share my story and to tell people and the medical community that leptomeningeal disease is not rare anymore. We're living longer, and there are treatments, that you can do, and you can, with aggressive therapy, you can recover. The name of the radiation I had, yep, okay, so it's called proton whole brain radiation, CSI, cranial spinal irradiation.
Michelle, that's excellent. Thank you so much for sharing your experience. At this time, Jalen, did you want to go ahead and jump up and share some information? Or seated is fine.
Skip to the slides here. Thank you, Michelle, for sharing your story. Okay. And so my name is Jalen Garrett. I do work at Sibley. I am one of the nurse practitioners there, and I do manage patients who have getting radiation to their brain or spinal cord. And so what I'm going to talk about is the symptoms of spread of disease from lung cancer to the brain and leptomengeal. So things that can occur: headaches, nausea, vomiting, seizures, speech changes, which can be slurred speech, word-finding difficulties. As Michelle mentioned, she had difficulty getting her words out, or a family member can say, you know, you're not sounding like yourself, or you're trying to get your words out, and it's very difficult. Vision changes to include double vision or peripheral field loss. Ataxia, which is loss of coordination and balance, which can be obviously falls or feeling like you're not walking your normal gait. Memory loss that can be short or long-term, changes in cognition, inability to concentrate or confusion, changes in behavior. This can be mood changes or personality changes depending on where the tumor is located in the brain. That can be, say what the changes in behavior could be. Other focal deficits can be difficulty swallowing, having one-sided weakness, loss of sensation, which is like numbness and tingling. That can be from the area of the tumor in the spine on down to the toes. Other symptoms can be neck or back pain, radicular pain, which is also like a shooting pain that can be in the spine and go all the way down to the toes. Motor weakness, numbness and tingling, saddle anesthesia, which is just what it mentions, the lower pelvis area, buttocks, anus, groin, inner thighs, having sensation of loss of those areas, bowel or bladder dysfunction, incontinence, which is leaking of urine or stool, or retention, meaning that you cannot go to the restroom. What is leptomengeal disease? It's a rare complication of lung cancer, and the cancer is spread throughout the cerebral spinal fluid, which can be from the brain down to the spinal cord, and the meninges, leptomeninges, which covers the brain and spinal cord, like the kind of wraps around it. Some patients can have a broad range of symptoms. Some patients can have everything. Some patients can have one or two symptoms, or they can be very vague. Some patients have less specific symptoms like headaches, nausea, vomiting, which can also mimic a lot of things, especially if patients are doing active chemotherapy or immunotherapies that also can have side effects from these symptoms. Potentially more cases in recent years because cancer patients, as Michelle mentioned, are living longer and have many systemic therapies that cannot effectively reach the blood-brain or cross the blood-brain barrier that gets into the brain to treat those tumors. And prognosis can typically be weeks to months. Diagnosing brain metastases to the brain and spine. So obviously we go off a clinical findings. So the patient is going to tell you how they feel. And it's important, as you can see from Michelle's story, to listen to patients, especially if there's something new that they have not experienced before. We can do imaging, which is an MRI of the brain and or spine, or a CT scan. Diagnosing leptomengeal disease to the brain and spine. Once again, clinical suspicion and exam findings. Imaging, MRI would be preferable, but based on sometimes patients' other comorbidities, if there's pacemakers involved or other implanted devices, that may not be possible, so a CT scan as well. And as you can see in these images here, these are showing the leptomengeal folds here and where they can be noticed on the imaging, where that's the spine, and of course this will be the brain, different parts of the brain. And in addition to imaging, another important aspect of diagnosing leptomengeal disease is getting a lumbar puncture, which is going to test the cerebral spinal fluid. So that can show high protein, low glucose, high lymphocyte count, or positive cytology showing malignant, which are cancerous cells. Sometimes there can be a high false negative, but for patients who do have leptomengeal disease or the features that show cerebrospinal fluid, it's normally not common for them not to have some sort of abnormality in their fluid analysis. And then Dr. Cutt will talk about how we treat these diseases. Share my mic on.
Thank you, Jalen and Michelle. So in terms of treatment, how do we treat lung cancer spread to the brain in general? A lot of the times it's a clinical judgment. Overall, the treatment commonly can involve surgery, radiation, or a combination of the two. The clinical decisions usually is multidisciplinary depending on the number and size of the tumor, the location of the tumor in the brain, how many symptoms and how stable or unstable the patient is, and the relative health status or performance status, meaning how much can the patient do day-to-day activities without assistance, or if they are overall sicker and needing a lot of help day-to-day. Usually the first step is that we generally administer steroids, especially if the patient has symptoms or if we see a lot of brain swelling with the MRI and imaging overall. The steroids were anti-inflammatory in general, so the goal is to control and reduce the swelling and reduce the pressure within the brain itself, which can temporarily reverse some of the symptoms. Surgery upfront is considered, especially when there is a single large surgically accessible tumor in the brain location. If this is a relatively new diagnosis, sometimes we do see patients who gets admitted to the hospital with symptoms but did not have a prior lung cancer diagnosis, for example, or as in Michelle's case, if has been cancer-free for many years and no history of distant metastasis before, and this is a new finding based on imaging. Finally, if the tumor is causing a lot of symptoms, a lot of swelling in the brain, sometimes surgery is also recommended to achieve rapid symptom relief, to take the cause of the symptoms, resect it, and usually achieve faster symptom relief prior to other additional treatments. With surgery alone, generally the control rates, because of the possible presence of microscopic tumor cells which are not visible by eye, it is possible, and literature have reported closer to 50% chance that the cancer can come back to the same spot in the brain. So for this reason, a lot of the cases after surgery, radiation is generally recommended to the surgical bed as well to improve the chances of local control at that particular location. Of course, every patient scenario is different, but overall, on average, the literature would report, the chances of the cancer coming back from the same site would probably drop from 50% to closer to 10 to 20%. All right, in terms of upfront stereotactic radiation, that is also sometimes recommended without surgery. Usually this is a very high dose radiation. You might also heard of the term radiosurgery, or by the name of the machines, which can be CyberKnife or Gamma Knife or linear accelerators. But essentially, even though it is called radiosurgery, no scalpels are involved. It's really meant to highlight the precision of this technique. It involves very high dose radiation to the cancer areas, and generally it involves 1 to 5 days of intense treatment, Monday to Friday. The number of treatment depends on the size and location of the tumor, and how close it is to critical structures such as the brainstem and the optic nerves. Overall, again, every patient situation is different, of course, but generally we think of stereotactic radiation if there are a limited number of tumors in the brain, especially if it's an oligometastatic case, when there are a few cancer spots in the brain, then stereotactic is generally a good recommendation, although we certainly have patients, say, with 10, 20 spots in the brain, and as long as they are relatively stable, and the symptoms are relatively well controlled on steroids and other medications, that can be considered as well. The reason we generally consider patients who are more stable symptomatically is because of the precision nature of this treatment. It can take closer to 2 and 2.5 weeks to plan at times. And so if we need an urgent intervention, then stereotactic radiation might not be the best approach to start. And in some of the images here, it's showing you, how the radiation works. So overall, the radiation works by having multiple beams into the brain area. The best analogy I can think of is pointing 20 laser beams to the same spot on the floor, for example. That way the cancer target gets very high ablative radiation dose, but the rest of the normal brain, as you can see in this picture here, for example, this is one of the cancer spots, and the radiation drop-off cools down extremely quickly. So you're really radiating a small area of the brain, and a lot of the normal tissues either see very negligible radiation dose or low enough that they have a chance to recover. Because of the precision nature with a lot of our brain radiation, we do generally recommend immobilization mask or surgical frame, something to keep the head position in exactly the same position during the treatment itself. As you can imagine, when the radiation beam is turned on, you want to make sure the patient doesn't accidentally sneeze and the radiation shoots in the eye or somewhere it's not supposed to go. So the immobilization would be very common regardless of the radiation technique. All right, so that's the stereotactic radiation portion. Sometimes we do also recommend that our patients get upfront whole brain radiation treatment, where the entire brain would be covered in a lower dose radiation to cover if there are many, if there are many cancer spots within the brain, for example. This type of treatment generally involves 10 daily treatments Monday to Friday, so about 2 weeks in total. The advantage of this approach is that treatment can be started relatively urgently. For an inpatient, for example, sometimes we can start later in the day or the next day, for example, and make sure we control the cancer and limit this and control the symptoms relatively quicker. If the patient is very symptomatic and there's one single large mass in addition to multiple other smaller tumors, but the large mass is primarily responsible for the patient's not feeling well, sometimes surgery is considered before whole brain radiation. If there are many, many spots in the brain, but the patient looks relatively stable, sometimes our colleagues do recommend hippocampal sparing whole radiation technique. The hippocampus is a very small area in the temporal lobe of your brain. It's on both sides of the brain, and it is small but mighty. It's responsible for making new memories, learning new tasks, for example. And so in some cases, because of the precision nature, to spare those small areas, it does take longer to plan, probably at least 1 to 1.5 weeks, which is why we can consider if the patient's symptoms are stable for the most part. All right, and systemic therapy, of course, has an evolving role, especially for any targetable mutations. As they have very exciting developments. I understand from your organizers that other sessions have discussed about systemic therapy in general, and I can't say I'm an expert on that because I'm a radiation doctor, so we'll be focusing on the radiation portion for this presentation. But of course, generally, for the best outcomes, a combination of systemic therapy and surgery plus or minus radiation generally would be key. All right, in terms of treating lung cancer spread to the spine, again, a lot of multidisciplinary discussion, clinical judgment. Usually when we evaluate the patient, we first start by seeing whether there are any spinal instability. If the cancer is eating into the bone of the spine, in some cases, the mechanical stability or the architecture can be a little bit eroded. Overall, radiation is very effective at controlling pain from the cancer itself and also from limiting, killing the cancer cells and limiting / stopping the tumor from growing further. However, if the pain is from mechanical instability, then radiation itself cannot change that, and that also leans into the surgery or radiation or both kind of questions. We also look at whether the patient have neurological symptoms based on the level of the spine that is affected, whether there are any concerns for the cancer starting to cause pressure into the spinal cord itself, whether there are any prior treatments to the spine, and the pathology of the cancer itself. Optimal treatment is complex and individualized to the patient scenario. If the patient have a bone metastasis within the spine itself, but they are relatively symptom-free, in some cases, observation might actually be recommended, especially if the patient has many cancer spots in the rest of the body, and the spine itself is overall, relatively limited and not thought to impact quality of life for the patient in the short term. Then close observation might be the best approach moving forward. In some cases, if the patient is oligometastatic, for example, meaning that there are just a few cancer spots in the body, there are systemic therapies available. Overall, we expect that the patient might have a long life expectancy. Stereotactic radiation upfront can be considered. There is a SABRE-COMET trial. I think the long-term data was published a few years ago, back in 2020, but essentially they were looking at patients with oligometastasis, and they find that stereotactic radiation to these spots can have a 22-month survival benefit. Of course, do note that this is a phase 2 study, meaning that it's usually done in a limited, single or limited number of institutions with a smaller sample size. There is a phase 3 study that's actively recruiting. This study is conducted outside of the United States, so we're waiting for the study to be completed and to look at the study, to results for that. If there is evidence of oligoprogression, this data is even newer, but there is a phase 2 study published just a couple years ago called the CURB trial, and they look at particularly for, first of all, oligoprogression means that, say, if the patient has multiple cancer spots within the body, throughout the body, but then because of systemic therapy, a lot of these spots are actually pretty well controlled, but there are only a few spots on imaging that seems to be continuing to grow or not improving, then we say that these patients have oligoprogression. This is relatively new area of research and study, but for this particular trial, they did notice a survival benefit in lung cancer patients with oligoprogression in particular. Again, a phase 2 study, so smaller sample size, and because it is a newer study, I don't think the phase 3 trial is even out yet to my knowledge, but certainly very promising, very exciting, and a lot of additional work to be done. All right, and again, systemic therapy also have an exciting evolving role outside of the scope of this session. If the patient has symptomatic bone metastasis, what do we do? And this can manifest as pain, or if the spinal cord is involved, neurological symptoms. For pain control, of course, our first priority is to make sure the patient is comfortable. So pain medications as well as steroids are generally the first line when the patient presents to the emergency room or in the hospital setting, for example. Steroids itself, because of the anti-inflammatory effects, can help to both limit the pain in the short term, and also if there are any pressure or compression on the spinal cord, to help temporarily relieve some of the symptoms. And that also goes to Jalen and Michelle's point that if there are symptoms, definitely let your provider know, especially when the spine is involved. For example, if the spinal cord has been, there's spinal cord compression for weeks or even 1 or 2 months, as time passes, passes, the pressure on the spinal cord can already be permanent. So even with steroids, there may not be any reversal of symptoms that are possible at that point with future treatments. But if it's, if the symptoms manifest within, for example, a day or two, the patient goes into the emergency room, we try to reverse it quickly with steroids while the team works on a treatment plan, then generally, hopefully, the outcomes are for the most part, are better in that perspective. If there's mechanical pain, we mentioned if the cancer is eating into the bone structure and the bone itself is unstable, usually the question we ask as a radiation oncologist is, for the pain in the spine location, first of all, where is it, and is the pain pretty much the same all the time, or is it particularly worse when you move around or bend or have particular movements? The latter, of course, suggests that it is a mechanical pain, in which case neurosurgery would be important in terms of evaluating whether surgery is possible on a case-by-case basis in order to limit that. In some cases, cement injection, the medical term is vertebroplasty or kyphoplasty. One is just a cement injection, and one involves a little bit of putting in a balloon to stabilize the spine further. Can also be a useful way to control the pain and provide a little bit of stability. And on a case-by-case basis, sometimes these are provided before radiation, sometimes the recommendation is do it afterwards as needed. Spinal cord compression with neurological symptoms, usually we start with very high steroids in an attempt to reverse any temporary symptoms before the team regroups and consider more aggressive treatments. All right, surgical management is usually considered if there's spine instability, if there's spinal cord compression, and post-operative radiation is also often considered to limit the chances of cancer coming back to the same area. There are stereotactic and conventional radiation approaches. The stereotactic is more precise, and the conventional radiation can be started more urgently. A lot of these are dependent on the patient scenario and how much time or how much stability we have, and how many cancer spots are involved when we make these decisions. All right, sorry, I'm starting to speak a little fast, so we are hoping to save a little bit more time for questions, Q&A session. So going back to the leptomengeal disease, patients with leptomengeal disease or LMD, in the past traditionally have limited treatment options, and prognosis can be weeks to months, as you have heard. However, there's a lot of exciting developments, hopefully a lot of hope in this field, as Michelle has demonstrated. Craniospinal irradiation, or CSI, is the radiation to the entire brain and spine area, and it is now an option for leptomengeal disease. Here in the picture, we are showing the photon CSI and proton CSI techniques. These are two radiation techniques used to treat cancer spread to the central nervous system in general. Photon is an X-ray based approach, so when the radiation goes in your body one way, it exits out the other end. Because of that, there can be a low radiation dose spillage, low to medium spillage to the chest area and to the abdominal area, which can cause a lot more symptoms for this treatment. So even though the photon CSI technique has been around for many years, honestly, as a radiation oncologist, we do not very commonly recommend that because it is because of so many side effects, and for an end-stage patients, sometimes a goals of care discussion and discussions of the benefits and risks are involved. But now that we have the proton CSI technique, proton is a heavy particle which does not have an exit dose. So with planning, as you can see in this picture, a lot of the times we can focus the radiation dose to the entire brain and the entire spine area, but the normal organs in the chest, the abdomen location, for example, can be much better spared, and patients tend to be able to tolerate the treatment much better compared with the photon approach. In 2022, Dr. Jonathan Yang, who is based at the NYU, had a preliminary phase 2 study with 63 patients with lung and breast cancer leptomeningeal disease, looking at proton CSI versus photon limited field radiation therapy. And what they find is in this preliminary study is that proton CSI have much better progression-free survival in blue here in terms of the survival curve. So progression-free survival meaning survival without the disease coming back to the central nervous system. And they were able to push the progression-free survival of PFS from 2.3 to 7.5 months, and the data is statistically significant. Because the data was so good for the primary endpoint, they ended the study early. So because of that, they do not have sufficient sample size so far to comment on overall survival, so meaning the overall time patient survives. But preliminary data shows that it went from 6 to 9.9 months. However, the statistical significance, they do not have enough sample size or adequately powered to make the conclusion on that, which is why we are actually actively recruiting for a phase 3 trial now nationwide, which is very exciting. Another important point, of course, is in terms of treatment-related toxicity, and this study finds that proton CSI compared to limited photon radiation have no difference. Keep in mind, the photon is limited field. For example, they will just treat your brain or parts of your spine, but this is not photon CSI. So overall, the treatment, the fact that the toxicity is similar is very encouraging. This is the NLG study. That's the QR code and the website. So Dr. Yang is the primary PI. We are enrolling on multiple sites. I think last I checked, I think San Diego, Missouri, New York, Hopkins and Mayo are about to be activated. We're just waiting for the final paperwork, and other locations throughout the US. So I'll definitely encourage you to go on the website and find out more information.
Okay, let's jump into some Q&A.
Hi, it's so great to see so many people here. My name is Cheryl Elliott, and this week I was diagnosed with LMD. Michelle, who I'm so happy to be here, has been an immense help in helping me find the right treatment program. And thanks to the panelists as well for being here. Very helpful. So let's get to questions. And I'm glad Michelle's here because she can also answer a lot of questions. And so just remember, I did have whole brain radiation, so I'm a little slow. Okay. So the first question is there a specific lung cancer oncogene that is more likely to spread to the brain?
Great question. I would say the medical oncologist is usually the expert on the molecular phenotype, so I wouldn't want to presume. But overall, I think from the radiation perspective, regardless of the molecular subtype, the treatment is very similar. Where we do customize is based on the patient individual anatomy and clinical scenario. I would say, it's hard to say. I think we have seen, lung cancer with different types of mutations, which could become leptomeningeal disease. Mm-hmm. Of course, we only see the patients who are candidates for radiation. So I might defer that to our local medical oncologist for that comment, for that question.
Great. The next question, and I think Michelle might contribute, is can you have brain mets without any symptoms?
Yes, absolutely. Yes, we have a fair number of patients who might be getting an MRI incidentally, for example, especially if it starts out very small. We had some patients who come to us, for example, with a 6 millimeter spot or even a 4 millimeter spot in the brain, completely asymptomatic. In some cases, you know, if it's so tiny, right, and if there are no other history of distant metastasis, we might repeat imaging in 6 weeks, for example, just to make sure there's a higher likelihood that this is cancer and not a benign incidental finding before we decide to treat. But absolutely, especially in the early stage, it's very possible to have a small spots of disease and you would not have any symptoms from it at all.
Right. And so next question is, Michelle, did you have symptoms, and how did you get to that diagnosis, which is so tough for LMD?
Oh, me, Michelle?
You, Michelle. Yes.
Yeah, okay. So LMD, I'm glad you asked that question, Cheryl, because LMD is by nature sneaky, and it's very difficult to diagnose. And it's most reliably diagnosed through clinical presentation, because you could have LMD and have a clear brain MRI. You could have LMD and have a clear spinal scan. And the cytologies in the lumbar puncture, which are a critical component to diagnosis, they have a low sensitivity, so they're only 50% accurate. So I knew that I had LMD when I heard whooshing in my ears, when I had trouble finding my words. And I think the most frightening part of the early diagnostic phase was when I passed out in my kitchen and my bladder released itself, and I woke up, you know, I don't know how long I was out. I was in a pile of my own urine. And so when things like that started to happen, you know, I really had to like raise the alarm, because my first 2 MRIs were negative, and the third MRI showed moderate disease. So you've got to really pay attention to those symptoms, because this disease, if you don't catch it early, it moves like really scary fast. And so it was really hard, Cheryl, because the MRIs were negative, the spinal tap, the first one was negative. The second one actually found the cancer cells, so I was diagnosed through a spinal tap.
Yeah, and how difficult was it for you to get an LP done?
Yes, it was nearly impossible. I almost died seriously waiting for it, because first of all, LMD pressure tests the hospital system, right? They're not prepared for this. They don't know how to coordinate care. And the radiology department, these are physicians who are, you know, specialists. They're not readily available because there aren't too many of them. And I had to fight to get that lumbar puncture. And in my institution, the lumbar punctures were only done Monday through Friday, 9 to 5. And I was in an LMD crisis on a Friday night. So I had to be admitted to the hospital for babysitting until a lumbar puncture could be available on Monday morning. So it was not an easy or pleasant experience, and but we got through it. We did get through it, but those policies still haven't changed. In fact, they've added like additional criteria for accessing a lumbar puncture, and unless you get the hospital administration involved at my institution, it's really hard to do. So no, it was not easy to get a lumbar puncture. I had to really get out of my comfort zone and make a lot of noise in order to do it.
Yeah. So self-advocacy becomes really important even when it's suspected that you have spine disease or central nervous system. Okay, now back to this. What are the chances of getting necrosis after brain radiation?
Very good question.
Yes.
Radiation overall, as it works to kill the cancer cells, of course, any normal brain, especially right next to the cancer target, can be affected as well. So radionecrosis is a term meant to highlight the possibility of the death of normal brain cells right near the cancer target. This is a lot more common, honestly, for stereotactic radiation, where we're giving very high ablative doses to a small area in the brain. For something like whole brain radiation or craniospinal radiation, because of the big area, the radiation dose is relatively limited. So I think the chances there are much more limited. But I would say that for stereotactic radiation, there are chances, and especially usually around the 1 to 2 year mark, if on MRI we see the treated spot suddenly looks a little bit bigger, usually we wouldn't just pull the trigger and say, let's treat it again, because it is very possible it's just a sign of the normal brain cells nearby having a reaction, and we usually would either do additional short interval imaging or discuss with the neurosurgeon on the best approach before we make the next step. So certainly possible, much more likely for high dose radiation.
Good. And the next question is, for patients with bony mets to the spine, which I also have, specifically thoracic lumbar, are they more susceptible to spread to the brain? Did that make sense?
Great question. Not necessarily, because if it involves the bone only, chances are it probably came from the bloodstream. So while it's always possible to have more cancer spots show up in the body, right? I don't think it necessarily increases the chance of the leptomengeal disease per se. Usually that happens if either the cerebrospinal fluid or the meninges are exposed. Then there might be a pathway to spread there. But if it only involves the brain, especially in the vertebral body and nowhere near the spinal cord, I think the chances are relatively more limited.
Okay. Let's see. The next question is, how often should patients get brain MRIs and at what stage of lung cancer? Why isn't there a standard guideline for brain met screening?
I'm sorry, can you repeat the last part?
Yes. The last part is, why isn't there a standard guideline or standard of care for brain met screening?
Oh, gotcha. Thank you so much for the question. Overall, for our patients who have evidence of brain metastasis, for example, the routine is to image at least every 3 months. Of course, if there are symptoms earlier, if there are higher clinical concerns, we would shorten that interval. I think the question might be, in terms of if you have early stage lung cancer, why wasn't MRI implemented at a regular interval? Of course, every time we do imaging, it's kind of a population-wide benefits analysis. A lot of the early stage lung cancer, do have high, relatively high cure rates. So from, I think a community, resource perspective, that's how the screening protocol and the intervals are established. But definitely, at the cancer societies, we review our national recommendation guidelines on an annual basis and make any changes based on the literature provided.
Okay, great. Thank you. So this is a long question, and I'm interpreting whoever asked it. If I get it wrong, I'm sorry. But so I guess the question is, does old metastases where do brain mets come from? And the question is, does old metastases seed new ones, or from primary lung tumor shedding more?
Gotcha. That's a great question. So where do brain metastases come from? Generally, that's when there's cancer cells starting in the bloodstream. Remember, cancer cells are very smart, right? Because that all originate from each and every one of us.
Yeah.
And so they do try to survive for as long as they can. So usually they start by shedding into the bloodstream and then essentially try to find a new home to grow and survive. Of course, overall the brain generally is it's a sanctuary because of the blood-brain barrier. So usually when it spreads, they do try to spread elsewhere in the body a little bit easier, but eventually some of the cancer cells might find a way to break through that barrier into the brain. In terms of whether the old metastases, I guess, can shed cancer or spread to new ones, it depends. If it's a completely dead cancer, right? If the cancer spot is completely dead and it's only necrotic cells there, then it shouldn't be able to do that. Of course, as with, say if you have a campfire and you pour out pour water on it, but if there's just a little bit of residual embers, a little bit of live cancer cells within that necrotic mass, and it eventually finds a way to break through, then absolutely it can migrate back into the bloodstream and try and communicate and try to find develop new metastases elsewhere, including the brain and spine.
Okay. So the next question involves Michelle. How does the protein type of radiation that Michelle had differ from regular whole brain radiation?
Very good question. So the difference is that in addition to the whole brain, the entire spine from the neck down to the pelvic area is also in the radiation field. So much larger radiation field in general. But it is true that both the CSI and the whole brain radiation, the whole brain will be exposed to the radiation in order to control the cancer cells within.
Yeah. And so, Michelle, do you have any comments on the specific radiation that you had? I had whole brain radiation. I didn't have proton or photon offered. So can you comment a little bit about that?
Yep, I was the first lung cancer patient at Kansas University to actually receive the proton whole brain radiation CSI or CSI, whatever. So as the first patient, no one could tell me like what to expect and what the side effects were. And what I would say is for anybody who has whole brain radiation, it's not as scary as it used to be. That's number one. And number two, the recovery period is quite a long time. And you go through something called the messy mix, where for a period of 4 to 6 months, you can't tell the difference between the disease, the side effects from the radiation, or the medication. And so you really have to have a recovery plan in place. You got to think about that with your team, because that messy mix period, there's a lot going on all at once, and you really don't know what's contributing to what. So you kind of have to hold fast until you're through that recovery period.
Thank you. And back on the necrosis, I know many of you knew Laura Greco, who was a fantastic advocate for us. I'm EGFR, exon 19, and she was involved in EGFR Sisters, and she did so much advocacy with the government, and she was diagnosed with LMD, but it was brain necrosis that actually took her in the end. So it is real and needs to be taken very seriously. Let's see. So next question. And this is a big question. I don't know if we can answer it here, but what exactly is LMD?
Pardon?
What exactly is LMD?
Oh, gotcha.
That's a big question.
Great question. LMD is leptomeningeo disease, meaning that the disease is essentially spreading through the entire brain and spine through either the cerebrospinal fluid or the meninges, which is the membrane covering the whole brain and cord itself.
Yeah, and it's correct me if I'm wrong, but the LMD, it's in the fluid, so it's in your blood. It is not in your bones necessarily. And when they do the LP test, which I didn't realize, what they measure is protein, which is very different than the level of protein that you have in your blood. And then they also can find cancer cells in that. So it's very important to make sure you get a lumbar puncture. And I had a hard time getting one myself. And so self-advocacy is really, really important when you have something in your spine or your brain or central nervous system, right? Would you agree?
Yeah, absolutely. Usually the combination of clinical findings, MRI, and the lumbar puncture are important in diagnosing. The lumbar puncture, if it is positive, it's a definitive diagnosis. That being said, the false negative rate can also be very high. But absolutely, I think a lot of the times, as you and Michelle have experienced, unfortunately, getting the lumbar puncture is a rate-limiting step. So I apologize that it takes so long to get that done. But absolutely, if you have any suspicions at all, I would recommend talking to your provider very quickly to get things moving.
Yeah. And, okay, sorry. I could stay here forever, so sorry. I guess it's time to wrap up and...
The Q&A is fantastic. There are so many great questions that we have not answered quite yet, and our team is going to work on how to get those answers to you. Michelle.
Yes.
Your
Hello.
longevity family loves you and is cheering you onward.
Thank you so much.
Let's give a round of applause to Michelle, Dr. Cutt, and our friend Jalen and Cheryl. Thank you so much to Michelle and Cheryl for sharing your experience and for this great information. Oh my goodness, thank you so much for being here.